Good morning.
Hi. Hi.
Good morning, Gabby.
Hi. Hey, how are you?
Good, how are you?
Oh my God, we have, wait,
Susan.
hi. Yes. No, I have seen the captions at the bottom and said, okay, this is very distracting. Oh. Hi, Suzanne.
Hi, Gabby. It's Tessie, actually.
Oh, Tessie. Hi. I was surprised.
Yeah, we share the link when it's a webinar, so
Oh, I see.
Suzanne's name, but it's
Well, thank you, Tessie, for all your help with this. Really, thank you so much.
Amazing organization. Like
Yeah.
no
with the
problem.
link and technological stuff.
So I have the PowerPoint because none of the panelists are going to present anything themselves. So it's just like a discussion. So we will lead that discussion. But we have all those questions that I sent you that you said you added there. So those will be at the beginning of the webinar. So we will present our.
Yes, I haven't done that before. Right now it's in like the practice segment. So I think we'll just launch and
I see.
you
Perfect.
know,
We will be reading them so people can do it. Perfect. And then once they answer all that, is there a way for me to have those results so I can show them at the end?
we have to play it. We have to play it by ear, Gabi. I haven't done that before. I think there's a way you click share results, but I actually don't know what it looks like. So we'll try our best, but I can't promise you I haven't done it before. It's probably possible.
Okay, let's try now. Hi, Dr. Olbara. Nice. Thank you for coming. We are practicing. Share results. Oh, and then I can show the results.
Nobody took it. Yeah, nobody took the webinar.
Stop sharing. 5 questions. Okay, I can end it this. Okay.
How it is going to show up? Are we going to click somewhere to see the results?
I guess
it's gonna show up on people's screens.
It will show on people's screens, yeah, like this.
Yes.
Like if I vote here, like whatever, click, 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 then I can share the results and it will look like this on the screen. So what we can do is that we can show the results after they take the poll. So they answer all the questions. And then we go to, with all what they say, we can then start talking to the panelists. So that will be easier. Okay, let me change that in the PowerPoint. So, bing. Let me delete this. There you go. Okay, so we can do that. Perfect.
Oh, now I cannot.
No.
So this practice thing that we just did is messing up my the poll.
Okay.
Relaunch poll. Relaunch.
There. Hi, Dr. Aydin. You're muted, so we cannot hear you.
Oh, yes. Hi again. How are you?
Good. How are you, Dr. Burca Aydin?
Thank you. Merhaba. In Turkish.
Merhaba hocam.
Hi, Agnes. How are you doing?
Good, and you? Hi, everyone.
Good.
I'm here. Just I'm muting myself.
Okay.
Gabi, do you want to display the PowerPoint?
Sure. Let me close this. Share. try to only share the PowerPoint. There it is. You can see it, right? Only the PowerPoint, not my whole desktop.
Well, you can make it a full screen,
A
but
presentation.
yeah.
Yeah. Okay, perfect. I'm just a brief reminder to Elif and Agnes. So I will start here. And then Elif, if you can just give a brief summary of the actual session in 2023. And then Agnes, just like a brief summary of all the panelists. And then we are going to, these are the questions, the poll questions, but they are also going to show on their screen. And then after that, I will, so Agnes, what you can do is just kind of read them. So people will be reading them on their screen and listening to you. And then I will show the results to everyone. And then we'll go questions to the audience. So to the panelists. So before that, I'm just going to explain here very briefly that this is not a presentation, this is an open discussion. And we hope everyone who wants to participate to give their opinion. We're going to assign questions to one or other of the panelists, but the idea is that everyone can participate at any point. So this first one is Elif, right?
Yes.
This first two, and Elif, feel free to ask everyone, like just to like redirect the question to one or other of the panelists. That is totally fine. And then this is your third question, Elif. And then these are yours, Agnes, okay? And same thing, just like anyone should have the opportunity to answer these questions or to give their opinions. And then here at the end, we'll have the questions from the audience that will be in the chat that I will read them. Okay?
Good.
All right, we have a plan. Let's hope it works. And Dr. Olbara and Dr. Aydin, do you have any questions for us? Hi.
Hi.
Hello, good
Hi.
morning or good evening, depending on
Good
which
morning.
part of the continent. So I've just followed your practice session. I honestly don't have any questions right now. I think it looks good.
Okay, perfect. And just feel free to jump in with any opinions, like even if we direct the question to Dr. Aydin and you say, well, actually, I would like to add or whatever, just this is open to anyone, like same thing, like we directed questions to each of you, all the panelists, just to have some structure to the program, but it's open to everyone to give your opinion.
That's fine, Gabby. I think it's pretty fine.
Okay.
Okay.
All right, I'm afraid I just missed. How will we proceed?
Sorry, say that again?
Is my voice can be here?
Yes, we can hear you.
We can hear you. Yeah, I'm sorry.
Sorry, I just missed the conversation.
Oh no, what I was saying is that we're going to start here, like present the team that organized this, and then Elif is going to give like a very brief summary of what was the presentation in SIOP 2023. Then we're going to introduce all the speakers or panelists. It should be actually.
Very good.
Gabby,
then,
go ahead.
Yeah.
Yeah. After you finish, I have one suggestion.
Okay. Okay, perfect. So then we have these questions to the audience that is like a poll, like they can answer while before we start the webinar. They're like short 5 questions. We will review very briefly the answers to that, and then we go through these questions to the panelists. That to have some structure to this program, we address these questions to a specific panelist to start with. Like, for example, this first one is going to go to
Dr. Lee Dupuis.
to Dr. Dupuis, but if you want to say what you think should be the top 5 priorities for high quality evidence-based supportive care, and you have an opinion about that, you're welcome to say, I would like to add these 3 points here that will be relevant for patients or whatever. So all these questions that we send them, all these questions to all of you.
Yes.
But what I basically was saying is that you should feel free to go ahead and say whatever you want to say. This is an open panel.
All right.
Tessie, yes, tell me.
Yes, I think we should not assume that people have seen the video recording from the Congress.
Yeah.
It was available, but I think I didn't see enough messaging from young SIOP, so maybe people didn't really get the detail that they should watch that video. Also, at the end, when you finish, please invite people to become members of SIOP and young SIOP in particular, and also to sign up to the Congress in Hawaii if they haven't done it yet. We try to always finish with some sort of advertisement of our own network and the upcoming Congress, just to get people interested. And in 5 minutes, I will open the session and people will start coming in.
Okay, perfect.
Thank you.
Why 2025, 24, so I don't forget. Skipping years here. Okay. Okay. Yeah, we should wait for at least Dr. Dupuis to come.
Dr. Freedman.
Yeah, and Dr. Freedman and Callum.
Hi, Dr. Freedman.
Good
Good
morning.
morning.
Thanks for having me.
Hi, good morning.
Thank you for
Thank
joining.
you so much. Yeah, thank you for
course.
joining.
Of course.
So I will repeat one more time. Sorry for the others that already heard me saying this a million times,
Sorry,
but
Gabriela.
Dr. Friedman, and I, Dr. Dupuis, how are you?
Fine.
Hi. So what I just say, this is like the structure of the PowerPoint we're going to present. We have some questions. At the beginning, we'll have some questions to the audience, and we will show the results of what the audience answered. And then after that, we have some questions for you that we prepared. But we will address the questions to one of you specifically, but feel free to jump in and add to that question, even an answer, even if it's not directed to you. So this is like an open conversation, because that's the whole point of this. Like no one has to present anything. It's just like extend the discussion, expand on the discussion.
Perfect.
All right.
Thank you. I'm having trouble with my video. I apologize. I think I should leave and come back.
Okay.
Okay, I'm sorry.
No, it's okay.
Am I here?
Yes.
Yes,
We can see
there
you.
you are. Perfect.
Good, good.
I
I think only Callum is not here.
yeah, he might be hopefully joining soon.
I had two invitations, one for a Google Meet webinar and one for the Zoom.
Yeah.
So I was on the Google Meet, so maybe Callum
Oh.
is doing the same thing.
Let me right now email him.
he's here.
Oh, he's
Hi,
there. Oh.
Callum.
Hi, Callum.
Hi. What's everybody?
Hi, how are you? Nice background.
Thank you.
Hello,
Very good.
everyone.
Guess it's morning
Hi.
there. Morning.
No, it's in the afternoon here.
Good afternoon, Dr. Burca.
All right. I don't know if you all know each other, but you've seen your emails in the emails that we sent you. But thank you so much all for joining us today. It's 10:01 my time, Tessie. I don't know how strict we have to be with time.
Yeah, we can open it. Are you guys ready to open it?
I think we're all here.
Okay, so I'll
Let me put this in presentation mode if that helps. Are we live?
Yep.
Yep.
People
Okay.
are coming in.
Okay, well, thank you everyone for coming here, for joining us today. This is our first Young SIOP Network Out of Congress webinar, and we're really excited to share this new initiative with all of you. That is basically an idea to try to expand on conversations and discussions about sessions that were very popular or well attended in our previous congresses. So this one is going to be about supportive care guidelines, and it's called Continuing the Conversation, Advancing High Quality Evidence-Based Supportive Care. So this is the team that helped to put all this webinar together. And we really want to thank Dr. Dupuis for her help to plan and to coordinate this webinar. So we just have to take a time to thank you for this. So this webinar will be based on this session that was part of the Ottawa 2023 Congress, that it was called How to Make High Quality Evidence-Based Supportive Care a Reality. When we sent the invitations to all of you, we provided a link to watch this great session, and we chose this one to be our first one as it was one of the most popular ones in the previous Congress. So now Elif, she's going to give a brief summary of what this webinar was about, this seminar was about.
Okay. Thank you for the introduction, Gabi. Thanks everyone for joining. It's very nice to see everyone here. My name is Elif. I'm originally from Turkey, but I'm now in the US. I'm doing my pediatrics residency here. Last year, I had a chance to listen to Dr. Lee Dupuis' presentation, and it was great. So I would like to briefly summarize the points that she made last year. So she firstly introduced us the clinical practice guidelines. She mentioned about COG and IPOC guidelines that are accessible everywhere, and the SPEEDY tool that they have implemented in sick kids. And she emphasized that the research evidence shows us we have a long way to improve symptom control. And she mentioned that it's very important that the organization values clinical practice guideline consistency to achieve high standards of care. And lastly, she inspired us to become the champions for supportive care in our institutions.
Yeah, thank you, Olivia. I guess something relevant that I will take for this session in 2023 was one thing that Dr. Dupuis said, that don't let perfection be in the way of improvement, which I guess it could be the spirit that we should all take with us when we try to improve quality care and supportive care in our daily practice.
Mm-hmm.
So now with this brief introduction, Agnes, if you can just present our panelists.
Thank you, Gabi, for that. And thank you, Ellie, for just briefing us on the presentation. My name is Agnes Chidedze, and I'm one of the pharmacists working in Malawi. And I'm also part of the team that organized this webinar. And I'm very excited to be here to talk about supportive care in different sectors. I'll go ahead and just introduce our panelists. And I think the first panelist is Dr. Dupuis, who I've already talked about. And Dr. Dupuis is a clinician scientist whose work focuses on the supportive care of children, and she works at the Hospital for Sick Kids in Canada. She has used the results of her research to develop clinical practice guidelines regarding treatment, related symptoms, prevention, and management that have been endorsed by the Pediatric Oncology of Ontario and the Children's Oncology Group and groups in several other jurisdictions. And Dr. Dupuis has also developed and validated important symptom screening tools, such as the symptom screening in pediatrics tool, and which evaluates 15 symptoms important for children with cancer, and the pediatric nausea assessment tool, which has changed the way clinicians evaluate nausea severity, which is a symptom that is important to patients and also their parents. And our second panelist is Dr. Jason Freedman. Dr. Jason Freedman is an attending physician in the Division of Oncology at the Children's Hospital of Philadelphia, and his research focuses on epidemiology and translational research within pediatric supportive oncology in oncology, pediatric oncology, and he's currently involved in several national supportive care initiatives and trials within the Children's Oncology Group, and it's a principal investigator, co-investigator of collaborative institutional trials focused on supportive care. And also Dr. Freedman serves on the antiemetics steering committee at the COG and is a vice chair of the pediatric study group within the Multinational Association of Supportive Care in Cancer. Our third panelist is Dr. Gilbert Olbara from Kenya, who's a pediatric oncologist and hematologist at MTRH, MY University Ampath. And Dr. Olbara has participated in multiple collaborative research projects in the field of implementation science, including the use of flow cytometry to enhance the diagnosis of hematological malignancies, and also the use of targeted therapies for pediatric lymphoma, and in modeling a virtual cancer education program for primary healthcare workers in Western Kenya. And Dr. Olbara also Dr. Olbara's work also includes building a pathway to optimal childhood cancer care at AMOI, a teaching and referral hospital, and throughout Western Kenya. The pathway also includes education to improve rates of diagnosis, intervention, and also to reduce treatment abandonment, development of treatment protocols for specific diseases, and also enhancing supportive care. And the results have been and it has resulted into an increase in the number of children diagnosed with cancer, and also reduced rates of treatment abandonment, as well as increased survival rates. Our fourth panelist is Dr. Guzide Burca Aydin, and she's a professor of the pediatrics and pediatric oncology at the University of Havitep in Turkey. And in 2009, she worked as a guest scientist in the pediatric neuro-oncology and stem cell transportation units at the University of Texas, Anderson Cancer Center in Houston in the USA. And she has become an associate professor at the Hasotep Hospital in 2012. And she's interested in childhood lymphomas and solid organ cancers. And also our last panelist is Callum Mullen, who is a childhood cancer survivor and a PhD student in epidemiology at the McGill University. He's a member of McGill's Division of Cancer Epidemiology, where he studies time to diagnosis and treatment in children. And as a survivor turned researcher, Callum is uniquely positioned to combine his lived and learned experiences to contribute to improvement of cancer care for future generations. I think those are the panelists that we have with us today. Thank you for joining us. We're very happy to have you.
Yeah, thank you. So we will very briefly would like to ask all our audience if you could complete a poll that is going to show on your screen. We're going to read the questions and give you between 5 to 6 minutes to answer them. It would be so we can discuss on this.
Yes, I'll go ahead and read the first question to the audience. And the first question is supportive care valued at your institution, or do you feel it is overlooked? And these are some of the options that we have that you can go to the poll and put in your answers. Our second question is, you have a choice, a single choice on one of these options. So the first one is, are you implementing high quality evidence-based supportive care guidelines at your institution? Are you planning to implement a high quality evidence-based supportive care guidelines at your institution? And the last option is, are you finding it almost impossible to implement high quality evidence-based supportive care guidelines at your institution? You can also go ahead and give out your answers. I will go ahead and read the other questions to the audience. Is, out of all these different supportive care domains, which one would you consider the highest priority to address at your institution? So you rank them 1 as the lowest and 5 as the highest. That is pain, infection, chemotherapy-induced nausea and vomiting, psychosocial support, or nutritional support. The other question is, have you ever done a quality improvement project? And you can also give your answer to that question, as well as, would you like to learn more about quality improvement projects?
All right, thank you, Agnes. So we'll give you a little bit more time to try to answer this.
Yes.
We have 70% of the participants that already completed this. All right. I guess we can just go with what we have. Tessie, should I end the poll and we will be able to see the results, right? Let's see. Are you able to see the results?
Yes, we are able to see in our screen.
Okay, I hope the yes, everyone. Okay, so for the first one, if supportive care you think is valued or overlooked, I think most people, 57%, consider that is highly valued, which is great. And then in this, the second question that asks if you're actually implementing any high quality evidence supportive care guidelines, 63 is planning to implement, but hopefully, the good thing is no one find almost impossible to implement a high quality evidence-based guidelines. On our third question, out of these different supportive care domains, which you consider the highest priority, what we'll see here that for pain, can you see here? So middle to high, the highest is 36% consider pain should be a priority. In terms of infection, also between the high and the highest are as a priority to include these as supportive care guidelines. Chemotherapy-induced nausea and vomiting, it's middle, not as relevant as pain and infection. Psychosocial or support is middle also, okay, 64%. And nutrition 50% of the respondents said that it was like a middle relevance. 64% of people here have done a quality improvement study, which is great, or be part of a quality improvement project. And almost all of you want to know and learn more about this. So this is important to us when we plan our next webinars. All right. I don't know what I'm doing here. Stop sharing. All right, so with this in mind, let's now go to our panelists, because the idea that we have here is that we can just expand on what was already said in the webinar in 2023, and to get all your knowledge and experience and advice for all young researchers that are part of the pediatric oncology community in the world, and how we can make this a reality. So Elif, go ahead.
Yeah, thank you so much, Gabi. So the first question to Dr. Lee Dupuis. Dr. Lee Dupuis, what do you think should be the top 5 priorities for high quality evidence-based supportive care?
Thank you for this question, Elif. Before I even try to answer it, I would just like to thank the organizers for bringing the group together and for prioritizing supportive care. This in and of itself is a bit of a milestone. It wasn't that long ago where if you wanted to speak about supportive care and actually doing something to improve it, it would be very hard to bring people together because it just wasn't on people's radar. So this really is a fantastic thing to see for someone like me who's been doing this for a very long time. So it's very gratifying. So thank you. So the question about priorities for this field, I can answer this from at least two different angles, from a research angle or a practice angle. So for the purposes of this webinar, I think we'll focus on practice and evaluating our practice with respect to evidence-based supportive care. And of course, priorities will vary depending on the context, right? The values that the individual has, the values of the institution, resources, etc. So this is just my personal take on this, and I'd love to hear different perspectives. But my first priority right now would be implementation of symptom screening as a standard of care, so that every child who's diagnosed with cancer internationally is routinely and systematically asked what their own supportive care priorities are, and that care would be directed based on that patient's rankings or concerns. I think that's at the core of supportive care. Supportive care is supposed to be supportive. So what one patient would feel is supportive, another patient would feel to be superfluous and really not a priority for them. So it's important to hone in on what each individual patient wants in terms of support. And there are several different validated pediatric screening tools that are available. And maybe one of your first actions would be to evaluate the available symptom screening tools, decide on the one that best fits your context, and perhaps translate it, do a little bit of validity testing within your context in order to go forward with implementation of symptom screening. So that would be my first, because it is very patient-centered. The second, and I think we're beginning to see this, would be to work to change your culture, or the culture within which you work, so that standardized evidence-based care is the default. It's what everyone, clinicians, patients, expect to happen. they don't expect care to be given one way on a Monday and another way on a Wednesday, depending on who the team is. And in doing this, this means that standardized, high quality, evidence-based supportive care is valued by the whole team and the institution. So the institution values evidence-based supportive care, clinicians value it, and families value it. So it is the default position of the organization. And what does value really mean? Of course, it means funding, right? So the institution actually funds supportive care programs. And a program, by definition, is evaluated. So there's some audit and feedback, audit around adherence to the institutional policy or care pathway, however you frame it, and also audit of patient outcomes who receive policy concordant care and those who do not. And if you're brave, you might also undertake an evaluation of health system outcomes. So what does it mean to your health system to provide care in this way versus another way? And through all this evaluation, you will have a better chance at sustaining your program. So that takes some very high level thinking and time to develop, but it's also important. And with all this sort of programmatic approach to supportive care, we hopefully will be able to identify patients who are at high risk of poor supportive care outcomes, whatever that is. And with that knowledge, we'll be able to bring added resources to those high-risk patients and prevent those poor outcomes. And machine learning in some situations may offer a tremendously rich way of identifying those high-risk patients. And even if when I say machine learning, you say, oh, that's never going to happen where I live, there are ways to translate the knowledge gained in machine learning to situations where machine learning is not feasible. So you perhaps develop a more traditional algorithm for identifying high-risk patients using the machine learning information. So don't discount that right off the bat. And then last, although I could go on forever, as you probably can tell, I think we need to work on empowering families and patients who want to be empowered, because not everyone does, but empowering those people to provide evidence-based self-care. So they are active participants in their child's care and or their own care. So I'll stop there, and I'm very interested in hearing what others have to say.
Yeah, if there's someone else who would like to explain what would be your own 5 priorities. I was very interested when you said that supportive care has to be value, and value means that there has to be an investment, right? Money to put in that, just to make that a reality elsewhere. And that's usually one of the main limitants that we all have everywhere, even if you live in a high income country or in a low middle income country. So what do the other panelists think about that particularly, which is always like kind of like a breaking point? And what would be your 5 priorities, or a few of them?
I just want to comment on Lee's point about the culture change, and I think that it underscores much of the work in this domain and area, that if you don't get your colleagues and the people in your center to believe the same way that this is critical, you can't influence change in a meaningful or a wider spread way. And so a lot of the work that we need to do is not just for patients and families, it's really on the internal structure and the internal organization and the delivery of this care. And I just think that that underscores so much of what Lee put forth in such a beautiful way about the future of our supportive care. I was also going to say that a bunch of us here were part of a paper that came out sort of talking about what we see as the successes and opportunities or the future of supportive care. So I'll put that in the chat box for people to read if they're interested, or just some ideas where similar concepts have been discussed. But I agree with Lee about many of these things, and putting the power back to patients and families to really want to take care of themselves and be part of their supportive care is also critical in my opinion.
And you think, Dr. Olbara and Dr. Aydin, that will be possible where you are working, like to move the power to the patients and the family? Is that changing culture already done or possible to be done?
Well, it's kind of difficult in low and middle income countries. These countries usually have more complex in their population, in their infrastructure. It's very difficult. In my country, it is much more easier because there's a national health coverage, so families and patients are more involved in the health system. But in most of the other parts of the world, and mostly in low-income countries, probably there is not, and there's much more difficulties even in accessing the care. So I would actually bring forward culture to implementing the high-quality supportive care into the patient care, because it differs in every societies, in every countries, and even in other parts of the similar countries. You know, there's another war in some parts of the world, and there are many displaced people, and we have to take their beliefs and sensitivities into consideration. Also, funding is another important thing. And again, low and middle income countries, the workforce, especially the educated or specialized workforce, is scarce in some of the countries. So it will be another problem for implementing high quality supportive care. I'm not saying this is unimportant. It's the most important thing, because if you have a strong supportive care guideline or procedure, standard of procedures, then the outcome of the cancer will be definitely much better. So I totally agree with Dr. Dupuis' suggestions, but in every country, I'm sorry, it's something popping up to my screen. In every country, you should be taking into your culture and the population, the needs of the population into consideration. It should be kept in mind.
So
And-
just,
Yep.
this is Olbara, Dr. Olbara. Just to add in, and thank you, Dr. Lee. I think you very well covered the main points, but I just want to talk about involving parents or empowering the parents. I know my colleague has said sometimes it's difficult, but we see this as an opportunity where I work. I work in Kenya, which is a sub-Saharan African. One of the biggest problems, actually two of the biggest problems, is investments in things like supportive care, in cancer itself. And the second is availability of resources, especially human resources. So one way to go around it, and it's part of the things that we do, is to empower the parents so that you increase the demand for this evidence-based supportive care. We have guidelines. We have guidelines that we've adopted or adapted from various, but sometimes even the healthcare providers themselves are not adherent, not because they want, but because the numbers, if you compare the numbers of the patients vis-a-vis the numbers of the nurses, then they may not be able to provide the adequate supportive care, timely measurements of, for example, fever or temperatures, timely administration of chemotherapy, following the protocol along the way. So one of the things that we are trying to encourage and using parents or empowering is educating the parents so that they know, I am expected to have my temperature measured, or I can have a thermometer and measure my temperature. That is one way of actually ensuring that there's adherence to the guidelines. The other way is chemotherapy. Because the system is a bit defragmented, then enabling or educating the parents on how the protocol is supposed to be ensures that their adherence reduces abandonment. So those are possibilities that we can actually harness or tap to look at how to ensure that there's reality or there's practicality in the evidence-based guidelines that we're going to use, especially the clinical practice guidelines. So that's just an example of how we can use empowerment as a possibility of overriding some of the challenges that are there in sub-Saharan Africa or low resource setups.
Those are great examples, Dr. Olbara. Just something simple as having a thermometer at the bedside, which is.
And then finally, just to add on, I wouldn't want to change so much in terms of the priorities, but I totally agree. I totally agree with Dr. Aydin that it has to be contextualized to the needs of that particular country or the organization. Really, the priorities are going to be the same, but the needs or the urgency of which one comes first depends really, one, with the needs of the patients, with the needs of the healthcare workers, and the priority of the healthcare system or the organization.
Thank you. Let's go to the next question, Elif.
Thank you for this great interactive discussion. And the second question to Dr. Olbara. So it's expected that sites adopt clinical practice guidelines based on their country's cultural differences and care expectations. Can you provide us an example from your practice of adapting clinical practice care guidelines and explain the reasons for this adaptation?
Okay. Thank you, and I'll take a leave from Dr. Lee also to thank the organizers for putting us together, and also appreciate my very empowered panelists with a variety of experience and years of experience. So this is a mouthful of a question because really part of it has already been addressed in terms of culture and cultural differences. And where I want to start is probably when you're talking about cultural differences and context, is looking at the poll result that we just had. So in the first poll result, you said infection and nutrition in this group would actually be in the middle. But if you take it to my context and you take it to probably Dr. Aydin's context, you'll find that one of the biggest or the most important supportive care would be actually infection being number one, and probably nutrition in my society. So you see, depending on the needs of the particular area, then you find that you have to contextualize any clinical practice guidelines. And there are three basic reasons that probably would want to put forth that are reasons why you want to contextualize the clinical guidelines. The first one is resources. So when you look at resources are at different levels. Even within an organization or an institution, there are different levels, and you have many competing demands for those infections. If you are in my organization, for example, a lot of these resources are going towards infectious diseases, so very little for cancer. So when you have resources for cancer, a lot of it is going for diagnosis and treatment, very little for supportive care. So that's an example of how resources are going to be influence the clinical practice guidelines. Then the second aspect, you see, when you're looking at resources, you're looking at various things. One is the health workforce. So why you need to contextualize this is because also the numbers of the health workforce within an organization or within a context is very significant in determining, because you're going to look at the skill set, you're going to look at the availability, and then you're going to look at their intrinsic motivation probably to implement a particular guideline. Probably it's not their priority, it's not a health outcome in that particular. If neutropenic fever, for example, in majority of the patients is not a priority when you're in a cancer setup or a cancer unit within a low middle income country. But the outcomes of these patients, blood and blood products, may be a bigger outcome. So that is just contextualization or cultural belief. Then the second point, I said the first one is resources, which you have to compete for. The second one is implementation package. How is the clinical practice guideline packaged within this context? So sometimes it is a national guideline policy that is pushed on the healthcare workers where they don't have any input, they don't have any motivation to implement, they have no understanding of it. Sometimes we feel like it is data or information from a high income country being pushed to us to implement. Then you develop lack of motivation to actually take it forth. But then this is very different when a clinical practice guideline is based on data from local settings. It is run by local champions, and then it actually has a direct impact on the patients. For example, our nurses would be very happy to note that just by having the mother having a thermometer at their bedside, it helps them in actually identifying a fever much faster than when one nurse has to rotate over 22 patients to take temperatures. So that's an example of how a packaging of a clinical practice guidelines would be important. Then the final one, which has already been mentioned, is about the acceptability and needs of the particular patients. So this is just an example of, is it acceptable? Is this clinical practice guideline acceptable to the people? Do they find it important at that moment in time? So when you are introducing, for example, a nutritional guideline or a supportive care clinical practice guideline for nutrition, then it's important because from the onset, we have significant malnutrition as a primary problem within our society. So this will make this particular guideline very useful for our patients. The second part of the question is, and I think that is cares also for care expectations, because improving nutrition on the onset is actually a faster outcome for the healthcare providers than treatment outcome of the patient in terms of cancer. So when they are able to have interventions or clinical practice guidelines that helps them identify high-risk patients at the onset, plan an intervention, and actually have this patient improve in the course of the treatment, that is a faster outcome. That is more appreciated. It's a positive feedback to the healthcare providers, much faster than actually the 5-year, 3-year event-free survival, which is the outcomes that everyone else would think to be more important. So these are actually factors that contribute to why cultural difference is an important aspect to consider at the onset when we are doing a clinical practice guideline. The third point, and probably, is that majority of these guidelines are actually, there's evidence that are from systematic reviews or evidence from high-income countries. So actually converting this to a locally packaged model by involving local champions, by involving local data, and actually adapting it, changing it from what is all around the world to something that has been adapted to the local context, will increase the acceptability of such data. Finally, I just want to talk about an example of, and I'll be brief on this one because I've spent a lot of time and it's actually covering most of this, an example of a local guideline that we have implemented, or clinical practice guideline. So one of the clinical practice guidelines that we are actually in the process of implementing at Moi Teaching and Referral, this is in Kenya, is how to effectively implement a fever treatment guideline among healthcare workers at our hospital, our children's hospital. It's called Sure for Africa Hospital. So if I start from way back, is that there are so many fever guidelines that have been or are available locally in various forums or actually on the internet. But then what we wanted to do is to have specific locally adapted guidelines that is effectively implemented by all cadres of healthcare workers, starting from the pediatric hemato-oncologist, the clinical officer, to the medical officer, to the nurses. And that is a project that we are trying to implement. And the reasons why we wanted to actually implement this is because it's based on data that we found. There were very significant gaps between what we knew and what we were actually doing. The know-do gap was very big. So everyone knew about this availability of fever neutropenia as an oncologic emergency. Everyone knew there were available guidelines, but there was evidence from a local study that showed we were not implementing, we were not using them. And the three aims that I'm going to raise are actually going to show us the statistics between, or the difference between what we knew and what we were doing actually. So the first one was just, the first aim of this guideline was to increase the knowledge and sensitization among healthcare workers at different cadres. Remember, when you're talking about fever neutropenia, it's not only concerning the pediatric hematologist, oncologist, it also concerns the nurses, it also concerns the laboratory personnel, because they're the ones who, when a hemogram is taken to determine neutropenia, they're the ones who are part of the team, of the team. So one of the things is to increase the knowledge across the continuum. Then the second one was to increase the amount of blood cultures that were taken at the time of a fever neutropenia diagnosis. Imagine initially the percentage of fever neutropenia of blood cultures that were being taken were 54%. And the aim was to increase it to 90%, because that is the ideal. Every time you have a patient with fever neutropenia, then it's ideal to take a blood culture so that you can subsequently alter the treatment based on the guideline. Then the final one was to actually improve the administration of antibiotics to within 3 hours of a diagnosis of a fever and neutropenia episode. The baseline facts was at only 7% of the children diagnosed with the fever and neutropenia were having their blood cultures being taken. So the aim was to increase this to 90% within a 12-period month. So what you can see clearly is that the reason why we needed to adapt this and actually implement a fever supportive guideline is because there was very significant disparity in the practice compared to the knowledge base. And this has actually been alluded to by many people who are actually looking at change model, behavioral change models, where presence of a guideline does not actually refer or does not actually directly correspond to change in practice. I think that answers the reason why we have a problem that we identified, we had evidence for it, then we needed to find ways to adapt the national or international guidelines to our setting using the evidence that is available and actually contextualized to our own settings.
Thank you so much, Dr. Olbara. We have 4 more questions, so for being on time, so we'll go with the next question. This is for Dr. Freedman. If you have to imagine your next supportive care QI project, what do you anticipate the barriers and facilitators of its success will be?
Thank you so much for having me and for asking that great question, which so many of the things that people have said already really fit into this nicely. And I think when you're thinking about quality improvement, especially with supportive care, you have to start by saying, number one, what is my problem? What am I trying to fix? And also, who do I need involved to solve that problem? And so if you don't answer those questions concretely and well, I think the rest of your downstream effects won't be effective because they won't meet the stakeholders where they are. They won't meet the patient families where they are. And quality improvement, unlike research, really is this iterative process that can be, you can do multiple things over and over to get to the answer quicker than you can with research, but you need to know who you're dealing with and who the target audience really is. So with all of that said, I think it's interesting that knowing where your barriers are actually leverages where your best strengths can be, because you just fix those and you can be on your path to success. So traditionally, barriers include time, right? People need effort and time to be able to solve and put attention to these problems. You need the resources, whether that's technology, whether that's, again, diagnostics like culture bottles or things like that. You need interest, right? If there's no interest in changing this culture or changing this practice, you're never going to make waves by yourself. You need the right stakeholders to all be in the room. Again, I've said this, but it really gets down to not just the physician or the parent or the patient or the nurse or the pharmacist. It's who's going to be doing the ordering for these supplies, or who's going to keep tabs on the data when we capture these numbers. So it's really every person that's going to be involved in the project. And I think one of the barriers is we get stuck in a mental model. We come to the table with solutions and we don't actually stop to think about the process enough. So we need to expand that and we have to see practice as it has been and get rid of that and see it as it could be and really open our minds. Because most quality improvement projects start with, I have a problem, I already have an answer, let's put something into place to fix it. And I think we need to come open-mindedly to the table. And then speaking to the culture change piece, just because something's been done a certain way doesn't make it evidence-based, and it doesn't make it the right way. And for us here, and I'll give you an example, is implementing the POGO nausea vomiting guidelines at our hospital was very challenging because we had a lot of senior clinicians who had been doing things a very long time in their own way and didn't either believe or want to take the time to really go through the guidelines or see how we were putting them into place and to teach the next generation of clinicians why those were important. So I think using all those and keeping those in your mind, the things that are going to facilitate your quality improvement project and be the successful story are getting the right stakeholders, finding people who have interest and a little bit of time. You don't need to have your entire existence be QI, but if each person puts a little time together, you can get this done. Education is critical. So education of about the project, once you decide what you're doing and how you're disseminating it, education to the staff and families and patients about the project, why we're doing it, but not just a one-time thing. Ongoing, repeated educational interventions was critical, especially in several of ours here, improving flu vaccination rates, improving adherence to the nausea vomiting guidelines. Can we go to specific providers and re-educate? Sure, if you have the time, but really general, high level, over and over explaining to people. And this is how it slowly creeps in and becomes the new standard of care. And with that, I think check-ins, informal touch bases, say, hey, how's it going? We deployed this, last week, last month. How is this working? Does it make sense? Is there anything I can help you with? More of a personalized touch base was very successful for many of our trainees, especially so that they could understand where to find the resources. At what point do we look at the guidelines before we make clinical decisions? And one of the obvious pieces, but one of the most often forgotten pieces, is the sustain phase. So we all know the Plan, Do, Study, Act, and we go through quality improvement projects to plan it, do it, test it, go back to the drawing board and get to a point where we think it's working. But when time is limited and resources are limited, the sustain phase and the generalizable phase gets forgotten. So we are guilty of this. We did a beautiful quality improvement project on improving flu vaccination rates. We got up to almost 75, 80% from 50. But because things change over time and priorities change, and then obviously COVID hit, we are back to doing a terrible job vaccinating. So we here are trying to do that again and re-educate and really think again, not just put the same project forward, but go back to the drawing board, start again. What are the new barriers? What are the new problems? What are the new opportunities? And reinvigorate the project so that sustain can be for a much longer time. So I love Lee's statement, don't let perfection stand in the way of progress. I think that is critical. And if we all remember that to move things forward, that will be critical. I want to also comment that in QI, in research, it's really important to know what's your outcome, what are you testing, and what's your outcome, the one thing or the secondary thing you're looking for. With QI, it's not as important. So don't worry about knowing which aspect of your QI bundle or your implementation bundle is making the most impact. When the stakes are high, like getting vaccines into children or like following evidence-based, doing the right thing takes priority. And so, again, our paper on flu vaccine speaks to this a lot. We put 5 things into place at once, and I'm happy to share that paper too, but we didn't care which of the pieces was the most important. We just needed the patients to get the vaccine. And so really saying, this is critical, we're going to do it all together. So those are my sort of use the barriers as your facilitators, get people who are excited about it, and don't forget the repeated nature of education, ongoing check-ins, and moving this forward to see the success come your way.
Thank you so much, Dr. Freedman. I guess we have another question to Callum. As a patient, did you know that there are supportive care guidelines designed to improve the patient care? And what was your experience with supportive care? And what would be the ideal and what can be done to improve it?
Thanks, Elif, for the questions, and thanks to Young SIOP for having me. As a patient, I didn't know that there were supportive care guidelines designed to improve my patient care. And perhaps that's kind of reflective of the second point that Dr. Dupuis had mentioned there, that it's so deeply ingrained in the culture of treatment at the facility that I was treated at, that it just becomes second nature. My experience with supportive care, of course, is ongoing. I was treated over 10 years ago. So it's so deeply weaved into each of the kind of encounters that you have with healthcare there. So it starts with, of course, nausea, vomiting, and now as I'm deep into survivorship, things just like psychosocial oncology, fertility are all kind of discussions that are happening. I'm surrounded by cancer in every part of my life. So I study cancer, I had cancer, but my girlfriend also had childhood cancer. And so the most recent example that we have with kind of experience with supportive care and survivorship is she moved from provinces, and of course, healthcare in Canada is fragmented by provinces. And so from moving from one facility to another and complaining about avascular necrosis, we were able to find a clinic that had a specific program that was able to offer more supportive care than just taking a leave or take Tylenol, and had an intervention targeted to improve her pain now and ultimately for the entirety of her life, which was something that we never thought was possible and wouldn't have been possible without the research and the iterative process of creating these guidelines and these care practices. What's the ideal for supportive care? I think I reflected it. Dr. Dupuis had mentioned it there, that we ingrain these practices in the culture of care, and that they just become second nature, and that they're so well designed that you don't have to think about it. And what can be done to improve supportive care? We also mentioned this point. All of my points that I had written down and thought about were discussed at any part here. And this is empowering patients and caregivers to kind of take on more of a role and involve themselves. Many people, I think, are more willing to participate than you would expect in their care. And so it's not something that has to be loaded onto a physician or a clinician. I think we can also do more we do an excellent job of establishing all this research and all of these care guidelines within the pediatric oncology realm or the AYA space, but we don't do a great job of getting this to the people who might be continuing the care, like the primary care physicians. We know that there are barriers there, that patients might not trust a GP with oncology follow-up care, and a GP might also not feel comfortable taking on this role as well. But I think we can do more to kind of share this knowledge and just kind of really round out the experience, create more holistic, so that everybody is more informed about the decisions being made, and we can know where to direct people if challenges arise.
That's such an important point, Callum, because when most of us think about supportive care, we frame that within acute treatment supportive care needs, without thinking of the aftermath, like as a survivor, how impactful supportive care still is for your life for the life of all survivors. And that I work in a low middle income country. So I would say for if it's hard to have supportive care for our patients, for survivors, it's extremely almost impossible, I will argue. So what is the experience, very briefly, because we're running out of time, but Dr. Olbara or Dr. Aydin, what would be your experience with, do you have any experience with supportive care adapted to survivors?
Excuse me, I lost some of the some connection. Can you repeat the question?
I was just saying that in most LMICs, I guess most of us consider supportive care something that is implemented in the acute phase of treatment, but not something that it has to be extrapolated and expanded through the lifespan of patients. So I work in an LMIC, and I don't see right now a way to expand supportive care practices to survivors. I don't see any in my practice, at least. So I was wondering if any of you had a way or seen supportive care being adapted for survivors in your setting.
Oh, yes, we do have, but I'm not quite sure it's the same as you ask. We have a survivorship program in our national setting in a Turkish pediatric oncology group. It's kind of a late effect study group. And maybe it can be felt like a supportive care group, because they have many issues in their survivorship period, and we try to solve the problem or expected problems to document, but not in a supportive care matter, mostly late effect setting.
That I get, it's kind of a reality elsewhere. But I think just, Callum, that is a great point that you just brought up.
If I can just add something in a minute. So
Mm-hmm.
I totally agree with Dr. Aydin. It's one, it really has to come to the context. It has to come to the needs assessment at that moment in time. If you asked me this question 1 year ago, I would ask you, why are you asking this? For part of the time we were dealing with abandonment of treatment-related toxicity, there were very few survivors. As we improved our treatment for these patients, now we get more survivors. Then you start asking, or there becomes a need for, how are we supporting this patient with survivors? So even in my setup right now, we are starting to have a survivorship clinic, not yet even completely started, but part of the issues that we are discussing with this survivorship clinic are issues that you're going to discuss in the next presenters about fertility. So those who were children a few years ago are now coming back to ask us, can I get a spouse? Can I go on to get children? Do I have risk of that? So I think it is really based on contextualized. Many early centers will focus on supportive care in the acute phase, intermediate phase of treatment of cancer. But as demand arises, as more patients come, then you get a requirement to start looking at survivorship and how to support these patients outside, as Callum has correctly put it very well. And the biggest thing is the link of stakeholders. So majority of the time, their problems are not going to be addressed by the cancer or comprehensive care centers, but then it's to empower the patients or the clients also to be able to have this done at the primary health care, the primary clinicians, the pediatricians in the county, because they can answer these questions. What it needs is just to have a clinical practice guideline, make them involved during the onset or part of the training or part of the education or continuous medical education, so that they are comfortable to do this at the community level. Thank you.
Thank you. Agnes, if you want to go to the, I guess.
Yeah, thank you, Gabby. The next question is, what can a young professional do to make a change and become an advocate for high quality evidence-based care in UMICs and LMICs? And also, how can we challenge our institution and colleagues to implement supportive care guidelines?
Thank you. Thank you for these questions and having me here. Well, most of the requisites are mentioned before, so I will be brief, and I believe we are out of time. But the first, it was mentioned about the interest, but I will add interest to a dedication, of course. We need to be dedicated for our purpose and for our willingness. And this topic itself presents the young SIOP's dedication and willingness about the supportive care topic. So if you live in a middle income or lower income countries and you need to implement a high quality evidence-based care, and if you don't have any, I would start with the urgent one. Start to observe, or maybe a small search. You can try a retrospective search, cross-sectional study, or any questionnaire, because when you add research to your guideline or supportive care or cancer care, it will become more reality and it will feed you, it will motivate you, and to increase your and your team's interest or dedication. And you need to identify the priority area. What is your need, the urgent need? Then you should ask the right questions, and these questions should be shared with your team. You should align with the other members of your cancer care team or in your institutions, because high quality care cannot be provided by one specialist or a single group of specialists. You need to align with nurses or other surgeons, pathologists, or even nurses, general practitioners, and other people. And you need to know capacity and barriers of your institution, even your the policies of your country. So when you assess the sets or standards of what you can adapt to your country, what is your need, as a young specialist, you need to align with your mentors or other colleagues' relationships, and build. You need to start a team, or at least involved in a team. And you need to decide what recommendation can be applicable to your institution or your setting. What is your patient's preferences? What can you present? What can you do in your part? So what the basic question is, which part of the research evidence you can apply it into your clinical practice? What a young professional can do is, I believe, it's mostly aligned with research. If you do a research, then your cancer care will be definitely improve, and outcome usually is parallel with your research, your integrated care. So you need to adapt or develop your clinical practice within these guidelines, but you definitely play a role in awareness, or asking questions, pushing forward, demanding higher quality. And you know that most kind of behavioral change takes time. With your input, with your push, it will definitely settles much better. So I think the most important thing is your dedication, your willingness, your willingness to research and adding something to your institute or taking care of your patients.
Thank you. That's very very helpful. And because we're running out of time, I just would like to open this question to all of you, because I guess you all have experience challenging your own institution to make your voice heard and like make supportive care a reality. So what would be one piece of advice for young physicians or young professionals trying to implement supportive care guidelines? If you could think of one thing or two.
I would suggest that you find your people, find a kindred spirit or two. Just on a personal level, it's so much more fun to work with a colleague who's like-minded, who wants to do the same good work as you, that you can collaborate with, brainstorm ideas. So find your people. I think that's key, no matter what work you're doing. And maybe start small. Look at a clinical practice guideline in an urgent area and look for a strong recommendation that you can adopt or adapt to your context, and maybe just look at implementing that and see where that takes you.
Anyone else has an advice? If not,
I think it's critical to not get overwhelmed by all the details, and again, not jump all the way to the end and say, how am I going to do this single-handedly? It speaks to Lee's point of having your troop and your group of people that believe in this, but slowly moving forward. Like, you know, you can't say I'm going to completely go from not using guidelines at all to perfect implementation overnight. It takes a long time. But what's powerful and amazing is that if you do small things over time, step by step, people start to believe and adopt and get it and say, oh, wait, let's go back to the guideline and look at this and be clear. And you'll be watching the masses do the right thing naturally over time. And so don't stress about the timeline. Just focus on small bits over time and people will start to buy in.
right. Well, great. I just, we're past the time, but I just really want to thank all of you for being so generous with your time and your experience and to share all this knowledge with us. We have some questions from the audience, but I will email it to you afterwards because we don't have time. And I just also want to tell everyone that if you're welcome to become a member of SIOP and Young SIOP Network, so please email us. We would like you to be part of our community. And also don't forget about Hawaii 2024. It's in less than 2 months, and we hope to see you all there if it's a possibility for you to come. All right. Well, thank you, all of you. Have a great day.
Thank you very much.
Thanks so much.